Medicaid and a lot of the other insurances, they have an annual renewal. So it's not just getting them involved. What's happening, or what are the plans for the renewal? Because you're saying it's coming from income tax.
Yeah,
Will it automatically renew if you meet the threshold, or
I
will
don't know
there?
the answer to that, but it's definitely one of the things that's on our list to comment on.
Because when I've seen churning before in another state system, it was less about the
Moving from income.
yeah, it was less about the income and more the fact that we had people on Medicaid who were placed on Medicaid, and these were perhaps not the people that were the most compulsive about getting their paperwork in on time. And so then they would drop off of it. They'd drop off, and it would be maybe a year before they'd have some medical emergency, and they'd pop up again. And now because I was in a highly managed and highly healthcare HMO state at the time, all Medicaid was HMO in their HMO system. So they'd have a provider panel over here that they were working with. They've dropped off. Now they're not getting anything. They're popping back up again, and they get reestablished with whatever is the next HMO in the pot, unless they declare that they were previously, or remember that they were previously with Blue Cross. So now none of the doctors that we had before on the same panel. You know, they're in different providers. It was a nightmare. So there needs to be some continuity.
Oh, definitely.
Of provider panels.
The churning I mentioned is one. The one you mentioned is another example. I mean, there's just all different reasons why someone who may be eligible and not actually covered at that time. And one of the things that we try to do, at least in our initial comments to that, it was old SIO, now it's CIO, because it moved under CMS, but it's the office that's in charge of implementing the exchanges and all of the health insurance provisions, we made a comment that, when you have this web portal of the system, is if I am already seeing a provider, I'm Medicaid eligible, and I have my doctor, and somehow my income rise above 133, that system, as I'm, the new information's in there, it tells me the plan where my current doctor is also a part of, so that from my perspective, I don't have to go find a new doctor, and that my care is continued. And I think it's very granular and nitty-gritty detail, but it's so important for the patients. It's comments like that I think will help make sure that they're thinking about the right thing from the patient's perspective.
And one option that would address that at least one state is looking at, is running Medicaid programs through the exchanges, and is outsourcing them through the exchange insurers.
The eligibility determination piece.
Yeah, that eligibility would be coming through the exchange, but that way it could be fluid.
Yes.
That is, the firms that are offering the exchange products would be basically the carriers for Medicaid.
Okay, that's a separate way, yes.
Yeah, but that would be a way of addressing
it. It is, and you get to that this is one of our issues. What you're getting at is a lot of members operate Medicare managed care plans. So, in a lot of the issue there is that in some states, Medicaid managed care plans don't have to meet the same requirements as nonprofit or for-profit plans. Some of the reserve requirements. What we try to make sure is that the definition for a qualified health plan, those that can play on the exchange, will make that same exception for the Medicaid managed care plans. Because so long as your state was okay with this plan operating, they should be okay on the state-based exchanges. But you're right, that is another way of ensuring continuity. Because if you have the Medicaid managed plan on the exchange, then certainly the patients will have that choice when they come. Okay, so I really won't go over the next two slides, but this is just some of the details if you're interested on the employer.
I think we're interested too.
Oh.
You're doing great, by the way. We really appreciate your patience.
Oh, not at all.
This is wonderful. We're going home with great stories.
You might want to consider the fact that you told us we could interrupt you.
I know. Well, I didn't know you guys as a group. Maybe next year I'll reconsider. Well, the prior slide was on just a little bit more details on the employer coverage. There aren't a lot of changes, but similar to the subsidies that they provide to individuals to purchase on the exchange, there is a other small businesses as well. And these are the, we talked about this earlier, if you're like 10 employees, your premiums really can't compare to a 500 employee employer. It's more similar to the individual market. So this is meant to help out some of the smaller businesses. And then the, Huang's promise about if you like your plan, you can keep it. This is the over 50 employees. There's a grandfather policy where if you grandfather policy as in if you have a plan that you like it, we're letting you keep it. You're not all required to move over to the exchange.
That last bullet is important. It says employers must offer voucher to, so employees below 400% of the FPL where their premium is 8 to 9.8,
Yeah, and that's the, I think we mentioned
The
earlier
max.
also. Yeah, the maximum.
But then it says employer, because we have a lot of organizations in this room who work with nonprofits that are small employers. So employer must offer voucher to be used in exchange. That's an important point.
No, that is, and I, have to just disclaim, I'm not an expert on the employer coverage piece,
Okay.
but if you are interested, we did a series of webinars right after health reform, and we did one focused specifically on employer issues.
Yeah.
So you can get a recording and also the slides from that on our website, if you're interested in more of the employer issues. Yes.
You talked about being exempt from penalties due to affordability exemption. Are there any other populations that are not required to have coverage?
There are, if you are religious,
Religious.
submit you to,
Okay.
there was an earlier slide with a block of text as a bullet that listed all of them out.
And then so if you are part of one of those populations, how's that enforced?
I don't know.
Okay.
But that's one of the other things that they have to work out, prior to 2014, hopefully. So, yes.
I know that as a small employer of between 50 and 100 employees, we ran all the numbers on this, and there's a great incentive to us to cancel all of our insurance and pay the penalty. It is a lot less expensive for us as an employer to pay those subsidies, to pay the penalty, and to not insure our people than it is to keep the coverage that we have. The question will be whether the employees can actually buy their insurance on the exchange at a rate equal to or less than what we're already paying. We're already paying a very high
And
premium.
whether they're getting the same level.
And
of
whether they'll
coverage.
get the coverage that we already offer them. And ours is not a Cadillac plan by any means. But as a company, we run those numbers, and there are tens of thousands, hundreds of thousands of dollars of savings for us if we do that. So when this small business piece was put in, it was an afterthought, even though there were a lot of us advocating at the national level for what about small business? And until we really see how this piece is gonna get implemented, it's gonna be incumbent on all of us to look at that for our agencies and for the agencies we work with, because this piece is the stepchild. This is the leftover piece. And so is that good for our employees? I mean, I wanna do, as CEO, I wanna do what's right for our employees. I want them to be as healthy and as covered as possible. I also have the fiduciary responsibility that if I can save $300,000, I gotta think about it. So is that gonna be a good thing for us to actually cancel our employer coverage and send those folks to an exchange, which Governor Perry won't set up? Or would it be, better for the employees' sake for us to continue to offer an employer plan? And that's gonna be a real question. And if we change our plan, because the premiums are going up so high between now and 14, everyone is trying to rack up cash in their tills at the insurance companies, planning for what they'll have to pay tax on in 14. Is it better for us to change our plan and pay the penalty for changing the plan, and then offer the money to the employees instead of to the insurance company?
Oh, there you go.
I mean,
A lot of that won't get answered until the exchanges are set up and the plans try to participate
That's
on
right.
the exchanges, and the market will shake out and figure out how much it costs and what level of benefits. Then you'll be able to see whether it's better for the employee, but like you said, regardless of that, you still have.
Insurance companies are not planning on offering cheap products because they want to profit. Okay, so you're not gonna see $150 policy out there that's gonna replace, a premium that you're paying $600 for. It ain't gonna happen.
So by when will the shakeout, well, I'm
Exchanges have to be up and running this fiscal year 2014, so it's actually October of 2013. So between now and October 2014 is when, as I mentioned, the regulation isn't out yet. So when CMS issues a regulation, then there's a 60-day comment period, and they take all of those comments into consideration, issue the final rule, and then fully implement it. That being said, they're doing a couple of things already. One is providing grants to states to beef up their HIT system to be able to run these exchanges and integrate their Medicaid eligibility determination system into the exchanges. So those grants are already out there, but again, if your governor won't take advantage of it, that's another discussion.
Yeah. Well, where does that leave us? If you have a Tea Party governor who would like to see Medicaid eliminated altogether, where are you on that?
You know, I have to say, my answer to that is there are a lot of rhetoric about wanting to get rid of Medicaid altogether. But at the end of the day, I think when they look at the numbers, they can't afford it. They are getting so much federal dollars to treat this population that if that goes away, you are either taxing your local communities, your providers, and your taxpayers. That the numbers won't work out to just getting rid of the Medicaid program. But you know, nobody really thinks of everything with a policy in mind. So
I would suggest if we brought this back to Ontario and showed this to our nonprofit brothers and sisters, we'd go bankrupt. We would have to close doors. We could not afford to provide that. It's not in the budget line. That I don't know even where we would find that.
You guys have to be concerned about that because your current policy, right? Is there anything you can change?
I don't think so. I think there would be a revolution.
Maybe other parts.
But there's a piece to this that involves all of our councils, and you had it on your last slide, which was that piece of outreach to get people enrolled. Not only is it a hard population to find and identify and maintain communication with, but if your state's having any kind of an IT problem with enrollment currently, and you're going to put this bigger piece of IT enrollment on top of that, the net result is ration by barrier. So even though the goal is that every person get enrolled, and that there's a penalty if you choose to, and you don't get enrolled, you're still gonna be subject to ration by barrier, which means you'll never get enrolled. In Texas, we're never gonna enroll them because the IT doesn't work. I mean, the rest of it's a moot point. We can't enroll them now. So there's no incentive to fix the IT system. There's no incentive to help providers do the improvements you're talking about unless you're a private system, and then you have your profit line, your profit margin. Taylor's got an incentive to do that. But there's no incentive, there's no way to incentivize people. So we're looking at what does that mean to the people that we serve who, you know, are still gonna have health issues. And we're still gonna have the IT problem, now it's gonna be worse. And now we're gonna have several million more people that we're going to be supposedly enrolling in a system that doesn't exist.
Well, building upon
And
that.
Parkland, who's your member,
Yeah.
Ron Anderson is having a heart attack, literally. Saying, oh my God.
Well, the same, I mean,